Weekender, organ donations, a slice of someone else's life? Friday, July 11, 2014. Image: in a world where our ability to play, make, do and mend with the human body seems to increase on a daily basis, Unknown Country looks at the subject of organ donation and its potential physical, mental, and even spiritual impacts. The transplant of various body parts has allegedly been attempted for thousands of years, with ancient records indicating that Chinese Dr. Pian Chiao swapped the hearts of warriors Gong Hu and Qi Ying as far back as 500 BCE, and that Chinese physician Hua Tuo used anesthetic to replace diseased organs with healthy ones. In modern times, however, the first successful kidney transplant was performed in 1954 by Dr. Joseph Murray in Boston, Massachusetts, and by the 1970s, drugs to prevent organ rejection had allowed transplant surgery to become common medical practice. The procedure has since enabled thousands of people to benefit from an enhanced life expectancy, and given the bereaved some small consolation that the death of their loved ones has not been totally in vain. There are strict rules of confidentiality surrounding the identity of organ donors in the UK, and recipients are told only the bare minimum of information regarding the previous history of the new body part. But strange things are reported to follow organ transplantation, causing many people to question the full implications of receiving another person's body part, or even just their blood. In the news today in the United Kingdom is a tale of a lady whose intuition led her to find the recipient of her son's heart 5 years after his death. Frida and John Carter lost their son, also named John, to a brain tumor in 2008 when he was just 33 years old. The family were told that organ donor John's heart was later successfully transplanted into a 14-year-old boy named Scott, but they were not told any other identifying information, and potentially the donor could have lived anywhere in the country. 5 years later, when Frida attended a memorial service for organ donors, she experienced a strange feeling when she read the order of service and saw that a man named Scott was speaking about his life-saving transplant. She knew without doubt that this was the man who had received her son's heart, and her intuition was proved to be right. When I sat down and turned the page on the order of service and saw his name there, a strange feeling came over me. I knew he was the recipient of John's heart, she explained to the Daily Express, putting it down to maternal instinct. Scott Rutherford's life had been saved by a last-minute heart transplant, and the donor was indeed a man named John. Frida and Scott's first meeting was a profoundly moving experience for them both, and Frida was able to hear the sound of her son's heartbeat once more. I asked him if I could feel John's heartbeat and he let me, Frida said. It was all I wanted. The day when we met was unbelievable, it was some sort of miracle, reported Scott. I felt like I was in a film. This may have just been a happy coincidence, but so many inexplicable incidents have begun to occur post-transplant that scientists are beginning to question the full impact of transplant surgery. Donor families who do have the chance to meet the beneficiary of their loved one's organ often describe how they are able to detect and recognize familiar personality traits in the new host. Jamie Sherman from southern Arizona was born with a heart defect and received a transplant in November 2001, after which she developed a craving for foods she had never eaten before, namely cheese enchiladas, bean burritos, and soft tacos. 6 months after the surgery, Jamie met the family of her heart donor, Scott Phillips, who told her that, yes, he had loved cheese enchiladas. Jamie also reported having a deep sense of anger after the operation, an odd reaction that she could not understand at a time in her life when everything was going so well for her. I couldn't understand where it was coming from, she said, but Scott's family were able to offer her an explanation. His mother told me, Scott died in a fight, said Jamie, who felt certain that this was the reason for her odd feelings of rage. Scott's mother also reported feeling the essence of her dead son through Jamie. His mother said to me, even though you have different color eyes, I can still see him through you, reported Sherman. Are these perceptions merely born of sentiment in the donor's family? Are the recipient's experiences simply the result of having life-changing surgery, or is there a more intriguing explanation? There is a weight of evidence that suggests each one of our cells carries a mini-memory bank, a biological device that carries previously held memories from donors into the new recipient. Some scientists began to recognize and research the possibility of cellular memory after heart transplant. Patients began to display strange cravings and mild personality changes. Major organs such as the heart, liver, kidney, and even muscles have been shown to contain large populations of neural networks, which can effectively function as self-contained brains and which could theoretically hold memories. Biological theories for this favor the presence of neuropeptides that facilitate communication between the brain and other bodily organs and for other organs to relay information back. The discovery that neuropeptides exist in all tissues, has posed the question of whether they can store memories. Gary E. Schwartz, PhD, has documented cases of cellular memory in 74 patients, 23 of whom were heart transplant recipients. One of the most astonishing examples concerned an 8-year-old girl who received a heart from a 10-year-old female murder victim. The recipient child suffered dramatic post-operative nightmares about the murder of a young girl. The dreams recurred and were taken seriously by her psychiatrist, who perceived them to be genuine memories from the donor. The detail in the dreams proved to be so accurate that the information eventually resulted in the arrest of the murderer. Despite these amazing and thought-provoking cases, only a few broad-minded doctors embrace the concept, and this field of research is generally disputed by mainstream medicine, who attribute that behavioral changes in patients after transplants to surviving in the face of death and being given a new chance at life. There could certainly be some truth in this, but some of the very specific effects described by recipients of donated organs continue to baffle doctors. Bill Wall almost died from cardiac disease in 2000, and was given a heart transplant at the University of Arizona Medical Center. A few weeks after the operation, Wall heard a song on the radio by British star Sada, an artist whose music he had never previously encountered. "I just started crying and rocking," said Wall, who, prior to his operation, had been a hard-hitting top executive with a tight hold on his emotions. He later contacted his donor's family, who were able to inform him that his donor, Michael Brady, had been a huge fan of Sada. Wall was stunned. "It was really, really freaky," he reported. From a spiritual perspective, organ donation causes some controversy. Most religions advocate the idea, seeing the body as just a container for the soul which lives on after death, and so consider the act of donation to be a virtuous deed that helps to save lives. Others, such as some Muslims and Jehovah's Witnesses, struggle with the concept, and it has been the subject of much controversy and religious discussion. Transplantation is now allowed for Jehovah's Witnesses, but can be confused by their refusal to accept donated blood. Judaism is also reluctant to agree to the unnecessary mutilation of cadavers after death, and ideally burial of the complete body 24 hours after death is preferred, as it also is in the Islamic faith. The desire to save lives overrides this belief in many Jews, as this objective is thought to supersede all others. Other spiritual schools of thought even suggest that it attracts positive karma to the donor, though spiritual research conducted by the Spiritual Science Research Foundation, an organization that aims to educate society on the spiritual dimension and how it affects our lives, has shown that when an organ is donated, a give and take account is generated, meaning that the donor will begin to have a karmic share in the sins and good deeds that the organ recipient subsequently commits after receiving the organ. Potentially this means, say the foundation, that donating an organ to an evildoer may result in us accruing sin. The foundation suggests that the unwanted spiritual effects of organ donation outweigh the positive outcomes. In general, it is best for the average person to avoid organ donation. This would not be a viewpoint shared by those who have had their loved ones' lives extended by amazing medical procedure. For them, the joy they have been given must surely count as a spiritual blessing. However, it seems that there is certainly more to organ donation than the replacement of faulty organs with working spare parts. If we expand the concept of organ transplantation to include blood transfusions, then vast majorities of the world's population will have benefited from the receipt of bodily cells from another human being. But are the Jehovah's Witnesses right to refuse to take in the blood of another?
Yep.
Does blood also contain the life force or essence of the donor? There is even less scientific evidence to support this theory, but various examples of anecdotal evidence are available from a variety of different sources. A forum post on the San Ramon Regional Medical Center website describes a personality change in a man who received a massive blood transfusion. Having served in both world wars, Dad was a very strict, military type, explains the user. After the transfusion, his strictness had gone. As one might say, he had become like putty in your hand. You could twist him around your little finger. Another post on a forum exploring cellular memory reads thus: 2 years ago I had major surgery and needed a blood transfusion a couple days afterwards. Once I regained my appetite and was able to eat, I craved junk food and fast food. I was a very healthy person before that. I was not a red meat eater, but now, I can't get enough barbecue ribs and bacon. I thought I was losing my mind. I have also lost my drive to do my daily jog like I used to, and the really crazy thing is that I am now a football wife. I never really liked sports before. I can add my own anecdote to these, as I personally experienced some very strange effects after receiving blood. I have always been a non-smoker, Yet after being the recipient of several pints of donated blood some years ago following the birth of my daughter, I suddenly developed intense cravings for cigarettes. I did not succumb to these cravings, but for many months following the transfusion, my desire to smoke was so strong that it took all of my willpower not to buy a packet and light up. I could even taste the smoke and the imagined sensation of drawing it into my body. These cravings have since subsided, but I have to report that whilst writing this piece, I would not have been averse to having a quick smoke. Go figure. Subscribe to Daylink to share your own personal views and experiences with us, here at the edge of the world.
Each year in this new millennium, pressures on healthcare systems mount. The growing number of patients, particularly the elderly, challenges healthcare providers' ability to meet patient needs with available resources. At the same time, legal and ethical voices increasingly advocate that patients be permitted a greater role in choosing their treatment. These developments especially affect one major sector of healthcare.
There's a growing concern on the part of physicians that our approach to blood transfusion needs to be reevaluated.
Today, at least 80% of the patients would strongly favor not to have blood transfusions.
News headlines show this. Both physicians and patients are faced with transfusion complications, supply shortages, and concerns about blood product safety. As just one example, the World Health Organization calculates that around the globe, unsafe transfusion and injection practices cause some 5 million hepatitis C virus infections each year. Increased efforts by national healthcare systems to achieve a safer blood supply have caused the cost of blood to spiral upward.
2 years ago, it cost us about 63 euros per unit of transfused blood. It now costs us 142.
Treating transfusion-related side effects has incurred additional costs.
These costs, which are indirect and delayed, are enormous and clearly would raise the cost of a unit of blood substantially.
The same holds true for compensation totaling billions of euros or dollars that have been paid to recipients of tainted blood and to their surviving families. As society faces these issues, transfusion risks and costs, is there a better approach? Might transfusion alternative healthcare meet patient needs and rights? Professors Earnshaw and Hetzer and countless other clinicians have responded to the requests of patients and of parents of minors. Consider 3 examples of complex surgeries performed without transfusion. Open heart surgery is consistently a major challenge. In Berlin, Professor Roland Hetzer explains why he had to operate on the tiny heart of a 10-month-old baby girl.
This child has a congenital heart defect, which is relatively rare. It means there is a direct communication between the left ventricle and the right atrium, which creates a continuous abnormal flow between the left heart and the right heart.
The defect was corrected with a heart arrest time of only 26 minutes, and the blood flow normalized. No transfusion was given. In fact, there was virtually no blood loss. Another example. Liver surgery usually involves considerable donor transfusion. In Jena, Germany, at the University Clinic, Professor Johannes Scheele here removes the cancerous portion of the liver from an elderly man.
How much was the blood loss today? 250 cc's.
No donor blood was given, and 18 hours later, the patient is chatting with the doctor in the ICU. Now an example of orthopedic surgery. In London, Royal College fellow Peter Earnshaw successfully performs a total knee replacement on an elderly woman, typically a high blood loss operation. All 3 successful operations were accomplished by surgical teams committed to respecting the patient's or parent's preference that donor blood not be given. Were these experimental operations by 3 pioneering surgeons? There are more than 100,000 physicians and surgeons in 150 countries who routinely treat patients without donor transfusion. Some experts feel
every anesthesiologist and surgeon should be interested in blood conservation strategies because it's good patient care.
When physicians who turn to transfusion alternative health care are asked why, they often cite as a major reason respect for their patient's decision. Professor Blumberg, director of a transfusion medicine unit and blood bank.
Well, I think there are a growing number of patients who are interested in being treated with either no transfusion or the minimum amount of transfusion possible, and there are some folks who strictly don't want to be transfused under any circumstances.
Another area motivating physicians and surgeons to change their approach is the growing evidence of inconsistent practices leading to unnecessary transfusions. Everyone concerned with improving healthcare or protecting the individual patient should consider some revealing studies on blood use. First, the Sanguis study. As part of a concerted action by the European Commission Medical Research Program, transfusion rates in 43 major teaching hospitals across Europe were analyzed. The ramifications of the Sanguis study are staggering. For the same type of operation, there were enormous variations in the number of units transfused depending on the hospital. In 1998 in Brussels, Professor Ball published a follow-up study.
All types of hospitals were included in the Belgian Biomed transfusion study for surgery, and we found exactly the same range of variability.
So we are left with the conclusion that variability implies that a lot of these blood transfusion components are being given unnecessarily.
A comparison of the 2 studies revealed another significant fact.
There were 2 centers which participated both in the Sanguis study and in the Biomed study.
Based on their findings in the Sanguis study,
they had somehow managed to reduce their blood consumption for major surgery. The mortality was the same before and after the changes. The hospital stay was shorter. The new procedures they adopted weren't very difficult to adopt, although they took time and took a considerable educational effort, but they didn't result in increased costs.
Soon after, in Canada, Dr. Hébert did a large-scale study of critically ill patients in intensive care. Professor Spahn evaluates the results.
I talk about the Hébert paper where they showed in more than 800 patients that less transfusion results in an improved outcome.
The obvious conclusion is that unnecessary transfusion translates into unnecessary labor and unnecessary cost. Besides patient demand and over-transfusion, many physicians cite as motivation to implement transfusion alternative healthcare the desire to avoid medical risks.
There's the risk of bacterial contamination in a stored unit of blood.
Bacterial contamination, whether occurring at donation or subsequently from improper storage, can cause infections having fatal consequences. In another arena, despite improved testing, viral infections continue to pose a serious threat. Experts are concerned about what the future holds.
Will existing viruses mutate and produce disease? There's no reason to believe that they won't.
The problem with contamination of transfusions, it always seems to be one step ahead of us.
In addition, blood transfusion induce a immunosuppressive state with the recipient, and that results in increased postoperative infections as well as earlier and more often recurrence of tumors.
We've estimated that approximately in the United States we can expect that 10 to 50,000 patients a year may be dying from transfusion immunomodulation related causes.
Likely, the most surprising and least recognized medical risk is human error. Giving blood of an incompatible type can cause a reaction ranging from mild to fatal. Professor Spence, a director of surgical education, acknowledges.
We can mix the blood up and cause catastrophe. Patients have died and do die from getting the wrong blood.
In fact, reports indicate that human error causes up to 1/2 of all transfusion-triggered deaths. In the light of such realities, patient decision, unnecessary transfusion, medical risks, as well as shrinking blood inventories and soaring blood costs, Professor van der Linden summarizes what many experts have concluded.
In view of the potential for a better patient care and a reduced healthcare cost, blood conservation is not an option. It's a must.
The good news is that safe, practical, and cost-effective therapies already exist.
The best medical care can be delivered without the use of allogeneic blood.
There are some very simple, very cheap things you can do which would help the majority of people, and this could be done in the smallest of hospitals.
Blood conservation is a very simple method which makes things rather smooth, less expensive, and with a better outlook for the patient.
The transfusion alternative techniques used by these surgical teams can be grouped within one of 3 basic principles, or pillars. The first is tolerance of anemia. Racing through the arteries, red cells carry life-sustaining oxygen to all parts of the body. The anemic patient has a low number of red cells in relation to his blood volume. If a person suffers extensive blood loss during surgery or as the result of an accident, the body can tolerate anemia to a considerable degree. Professor Moore, an acknowledged pioneer in trauma surgery.
Studies have shown physiologically that the human being can tolerate much lower hemoglobin levels than previously assumed safe.
The medical community is starting to realize that tolerance of a significant anemia is doable for patients.
However, anemia is tolerable only when the body has sufficient circulatory volume to continue to function.
We also know that with that anemia, we can compensate with volume, because volume is the critical component here to maintaining blood pressure.
With low-cost blood volume expanders being available, current medical opinion increasingly abandons the arbitrary rule proposed back in 1942, that a hemoglobin level of 10 was the transfusion trigger, or the lowest acceptable figure before administering a transfusion. Thus, Professor Earnshaw notes his first step in implementing a transfusion alternative program.
I halved our transfusion rate by simply saying, could we lower our triggers from 10 to 8? And just taking a little more control over the decision. That was very easy. That cost nothing.
Simply implementing the first pillar would cut out millions of transfusions and save billions of euros or dollars annually. The second important principle in transfusion alternative strategies involves stimulating red cell production in the patient's body. This is important for an anemic patient before surgery, and it can speed recovery after extensive blood loss. Studies directed by Professor of Obstetrics Albert Huch have shown
sufficient iron supplementation can already normalize the blood count to a large extent and at relatively little expense.
In selected cases, the genetically engineered drug erythropoietin, commonly called EPO, can be used. Professor Mercuriali, a director of transfusion services, explains.
Stimulated by the administration of erythropoietin, there is an acceleration of production of new red blood cells.
The third principle, or pillar, is to minimize blood loss.
The most important technique to control bleeding is to avoid bleeding.
Meticulous surgery is practical and cost-effective. A variety of tools can be used to assist. For example, electrocautery devices enable surgeons to cut rapidly and to seal blood vessels immediately. There are also modern drugs that can reduce bleeding. Some are applied directly to the bleeding area. Here, a fibrin glue pad is used to stop blood from oozing out of a dissected liver. Professor Baron notes about the cost-effectiveness of such agents.
The decrease in intraoperative bleeding and the decrease in the use of blood products compensates for the cost of the drug.
Another effective technique to minimize loss in instances of heavy bleeding is to salvage the patient's own blood. Recovery of as much as 50% of the blood otherwise lost has become a reality. This technique also meets the ethical needs of many who absolutely refuse donor transfusions. For instance, some of Jehovah's Witnesses have allowed cell salvage to be used. There are even such machines designed for small children.
Cell salvage is a very important technique because when you use cell salvage, the blood lost by the surgeon is not lost for the patient.
Many other beneficial strategies are available. All assist in avoiding the risks and societal costs of millions of transfusions. To illustrate the impact of properly combined techniques, consider the task faced by the medical team of 4-year-old Luana in Modena, Italy. She was born with a serious heart defect. Her team, headed by Professor Marcelletti, chief of cardiovascular surgery, had to perform a series of complex operations. As requested by Luana's parents, the first operation was successfully done without donor blood. Once again, for the second procedure, there were both skilled personnel and the appropriate equipment, including a cell salvage machine. The meticulous surgery, utilizing electrocautery, took 2 hours, and Luana lost only 100 milliliters of blood. Her parents were delighted, and the medical team was pleased with the outcome.
We have performed the operation without the use of blood transfusion, as we try to perform with all of our children.
I think all these little babies deserve not to be transfused and not to take the risk of blood transfusion.
Further proof of the effectiveness of heart surgery without transfusion is provided by Dr. Rosengart.
When we looked at a series of 50 Jehovah's Witnesses patients and 100 patients in the general population, we found a shorter length of stay and a lower cost using our blood conservation strategy.
While many clinicians would hold that some situations absolutely require blood, what is the view of those experienced in the use of transfusion alternatives in life-threatening emergencies? First, an anesthesiologist's perspective.
The cessation of bleeding, whether surgically or in other means, must be the first principle. It's important to act quickly and to keep in mind that modalities are still available even in a trauma situation.
Next, a surgeon's perspective.
In any trauma patient with a significant blood loss, I would always prepare the cell saver system.
In one of the busiest trauma centers in the United States, Professor Cohn, Chief of Trauma and Surgical Critical Care, notes about patients declining donor blood.
We see more than 3,000 patients a year here that are Jehovah's Witnesses, and we do about 250 to 275 major operations on them each year. And what we have seen in our population is no increased length of stay, no increased mortality. In fact, it appears to be somewhat decreased.
On the basis of such experience, many physicians conclude that, overall, transfusion alternative health care is cost-effective.
Well, one of the beauties of transfusion alternatives is that the most effective alternatives are generally the cheapest.
There's no doubt that blood is a costly product. We've been able to reduce our blood transfusion bill for the liver transplant program here by 70% since we started adopting new techniques, and that equates to hundreds of thousands of pounds in a year. And it's far more than the costs of the drugs and the other therapies we use and the mechanical methods we use for reducing blood loss.
It takes more dedication than technical means. These similar results can be achieved without the use of costly machinery.
And transfusion alternative healthcare has a benefit beyond saving money and meeting patients' physical needs. There is an ethical benefit. This care honors the patient's freedom of choice to accept or reject a certain treatment.
One of the primary principles of good medical care is being concerned about what the patient wants.
Professor Harding, who teaches ethics to medical and law students.
Today one would link that ethical duty, not to do harm, to seek the best possible outcome for one's patient, with another duty, which is to respect the autonomy of the patient, to respect the patient's own views and decisions.
At Glasgow University, Professor of Law and Ethics in Medicine, Sheila McLean summarizes.
Doctors have virtually an absolute obligation, both legally and ethically, to respect the patient's choice.
Concerning the advancing legal view generally designated patient rights, Professor Guillot, founder of the Health Law Institute at Neuchâtel University.
I believe the basic element of patient's right is the right of self-determination. That is, the right of any patient to decide what shall be done with his or her own body.
Patients have a right to be told that there are alternatives, and more than that there are alternatives. What are the respective risks and benefits expected to be associated with those?
Concerning the evolution of patient rights, Professor Weissauer explains.
Earlier, the doctor determined how to proceed and thereby shouldered the entire responsibility. In the course of time, the relationship has changed more and more into a partnership, doctor and patient meeting each other with full equal rights.
Recognizing patient rights accords with the UN's Universal Declaration of Human Rights. In fact, these legal issues have become so important that in 1997, the Council of Europe formulated the Convention on Human Rights and Biomedicine. Article 5 proclaims, "An intervention may only be carried out after the person concerned has given free and informed consent to it."
The doctrine of informed choice says that it is up to the patient to accept or to refuse any kind of medical act, for instance, a blood transfusion.
Addressing a sensitive issue, Article 6 states, "The opinion of the minor shall be taken into consideration as an increasingly determining factor in proportion to his or her age and degree of maturity."
There's no doubt that minors, in a legal sense, can and very often are able as adolescents to take decisions about their own treatment and their own health.
How does freedom of choice for patients and parents work out in practical terms?
Well, if the physician cannot think of finding a way of accommodating patients' desire about alternatives to blood transfusion, he should try to refer the patient to one of his colleagues or to another institution or healthcare facility where this alternative is really practiced.
But what about emergencies, where the victim may not be able to speak, to convey personal conviction?
It's now recognized that people have the right to indicate treatment choices in advance. And this takes the form of a written document where the patient shows that they have considered certain situations and they've taken a clear position about a treatment choice.
In an emergency, one would always also search for an advance directive or a durable power of attorney, for instance, in the wallet of the patient.
Respecting patient rights also has healthcare benefits.
There is empirical evidence that patients who feel engaged in their treatment are likely to get better quicker.
Consider, for example, a case at St. Richard's Hospital in Chichester in southern England.
Well, Mrs. Whittington had arthritis of her hip, which was so advanced that she required a total hip replacement. She is a Jehovah's Witness and therefore declined to have a blood transfusion.
Well, I do believe that God's word is against taking blood, and we should appreciate that God's word is the truth. Mr. Patel was quite happy to do it without blood.
It is the doctor's responsibility to listen to patients' demands, listen to what they have to say, and to give them an informed choice of alternatives.
In frank dialogue between physician and patient, the question of whether she would accept cell salvage arose.
When I knew more about the machine, and it was explained to me, and said I would accept having the machine.
The relationship between the patients and the medical staff is excellent here. We have a very open culture and a good learning environment.
What was the outcome of this cooperative approach?
The strategies that we used intraoperatively during Mrs. Whittington's operation were meticulous hemostasis, salvage of blood using a cell saver system, as well as using a cemented hip replacement. She tells me that she is delighted with the operation in terms of the pain relief.
As Earth's population continues to grow and age, their medical needs will be a greater challenge to healthcare structures, many of which are already struggling. In this regard, transfusion alternative healthcare offers a promising direction.
A well-adapted blood conservation program means a decrease in the total cost for the patient, but also a decreased cost for the society.
While all medical interventions involve risks, transfusion alternative healthcare uniquely meets both patient needs and rights.
I can foresee that in the future, patients will almost expect that any surgery which is necessary is carried out without blood transfusion.
Patient empowerment is important, not only to better respect autonomy, but to promote good medical treatment.
The various steps to reduce the need of blood transfusion nowadays are very well established, well tested, and they are certainly safe.
This is universal, can be practiced in any institution in any part of the world.
Blood conservation is a safe, effective, and progressive medicine.
This is the best way of treating patients and clearly should be a standard of care.
In Berlin, Professor Roland Hetzer at the German Heart Institute corrects a ventricular septal defect in a 10-month-old girl. In Jena, Professor Johannes Scheele at Friedrich Schiller University Clinic performs a liver resection.
Roughly 30%, which is left behind.
In London, Peter Earnshaw, a fellow of the Royal College who practices at Guy's and St. Thomas hospitals, performs a total knee replacement. Challenging surgeries, but they share an added dimension. In each of these cases, the team had committed itself to operating without allogeneic blood transfusion. Today, in 150 countries, more than 100,000 physicians have made a similar commitment to bloodless medicine and surgery because they believe transfusion alternative strategies are simple, safe, effective. Many view the pioneering bloodless major cardiovascular surgery of Dr. Denton Cooley in the 1950s as the beginning. He cooperated with patients who are Jehovah's Witnesses and who, while seeking quality medical and surgical treatment, do not accept allogeneic blood transfusion. They observe the biblical injunction, abstain from blood. In 1977, Cooley's team published a report on their 20 years of experience with a consecutive series of 542 bloodless cardiovascular surgeries. The report noted an acceptably low risk. Professor Richard Spence, a pioneer in transfusion alternative strategies.
The lessons we learned in the early stages of bloodless medicine and surgery with the Jehovah's Witness clearly translated over to all of the rest of our patients. So the field now really of blood conservation includes the use of multiple alternatives in a planned way to avoid the need to transfuse a patient with someone else's blood. We have operated on newborns, we have operated on people in their 90s, and we use these same techniques and approaches.
Professor Albert Huch, speaking of efforts in the general patient population.
In dieser Ära
In the era when the risks of blood transfusion were not realized as they are today, 15% of all women in such a group of at-risk patients received blood. Today this figure is far below 1%, even though we are a center for complicated cases.
We've now reduced our transfusion rate for knee replacements, revision knee replacements, I think of the order of 5 to 8%. Ideally, we'd like to get it down to 0.
Professor Hetzer points to one reason for such efforts.
Today, at least 80% of the patients would strongly favor not to have blood transfusions.
And for legal and ethical reasons, today attention is increasingly being given to respecting the wishes of the patient. Experts also cite their desire to avoid medical risks related to transfusing allogeneic blood.
Any unit that is donated into the blood bank, whether it's an allogeneic unit or a PAD unit, there's always the risk of administrative error and an ABO mismatch and a fatal hemolytic transfusion reaction.
Side effects include not only the transmission of viral diseases that everybody talks about, like HIV or hepatitis B or C, but also new viruses that are prevalent in the donor population. Also, parasitic diseases are more and more transmitted via blood transfusions.
The public health impact of transfusion immunomodulation is very difficult to estimate, and we've estimated that approximately in the United States we can expect that 10 to 50,000 patients a year may be dying from transfusion immunomodulation related causes.
Will existing viruses mutate and produce disease? There's no reason to believe that they won't.
Many see these risks and the resulting costs, but feel that they have no alternatives to allogeneic blood. However, even the benefits of present policies on the use of allogeneic blood come under question in view of a groundbreaking study by Dr. Paul Hébert of Canada. It compared a liberal transfusion policy with a restrictive one in critically ill ICU patients. The results were surprising, particularly the mortality rates.
I talk about the Hébert paper where they showed in more than 800 patients that less transfusion results in an improved outcome.
Other evidence showing the need to review policies on the use of blood comes from 2 earlier studies. Consider first the Sanguis study, published in 1994. Part of a concerted action of the European Commission's Medical Research Program, the study analyzed transfusion rates in major healthcare centers across Europe. 43 teaching hospitals were prospectively studied as to their routine transfusion rates for 6 common standardized operations. The Sanguis study revealed that different institutions routinely transfused drastically different percentages of patients for the same surgeries, varying from 0% at some institutions to 96% at others on coronary artery bypass graft and from 0 to 100% on total hip replacement.
The main lesson is the variability of transfusion practice from one center to another for the same specific operation.
In 1998, in Belgium, a follow-up study was published.
So all types of hospitals were included in the Belgium Biomed transfusion study for surgery. And we found exactly the same range of variability.
So we are left with the conclusion that variability implies that a lot of these blood transfusion components are being given unnecessarily.
However, there is a positive note regarding 2 Belgian hospitals that participated in both studies. After the Sanguis study, they changed their transfusion policy.
They had somehow managed to reduce their blood consumption for major surgery like colectomy for cancer by a factor of 5 at least. The hospital stay was shorter, so we have no evidence of increased morbidity nor mortality.
In the light of what has been learned in the last few years, Professor Philippe van der Linden summarizes what many experts have concluded.
In view of the potential for a better patient care and reduced healthcare cost, blood conservation is not an option, it's a must.
But what is the foundation for an effective transfusion alternative program? Experts agree that it is a team approach.
It truly has to be a cooperative effort, a team effort to the approach. And it has to be tailored to the patient's condition as well as the operative procedure. Some techniques are appropriate for some procedures and some surgeons, and not for others.
The various transfusion alternative techniques used by successful teams can be placed under 3 basic principles or pillars.
Preoperative planning involves to realize that a patient has not enough endogenous red blood cells for a planned operation. And this depends not only on the hematocrit, but also on the estimated blood volume of a given patient, the estimated blood loss that the planned operation is associated with, and also the transfusion threshold that can be considered reasonable or tolerable in this individual patient.
The first pillar can be defined as appropriate tolerance of anemia. This involves reconsidering the standard policy on anemia treatment. Some still use a transfusion trigger of a hematocrit of 30% or a hemoglobin level of 10 grams per deciliter for all patients, thresholds that date back to an article by Adams and Lundy published in 1942.
I am really convinced that there is no place for the magic 10 gram.
Our experience with Jehovah's Witness has shown that, first of all, we don't need the hemoglobin levels we assumed were essential previously.
But there should be no hard or fast rule, or there should be no trigger. You can anesthetize patients for some procedures, depending upon the patient, as low as 2 or 3 grams if necessary.
All experienced physicians stress the importance of maintaining normal volemia via simple volume replacement. With adequate volume, oxygen consumption is maintained over a wide range of hemoglobin levels. According to Professor van der Linden, the 2 main mechanisms responsible for the maintenance of adequate tissue oxygenation are an increase in cardiac output and an increase in tissue oxygen extraction. In the range of hematocrit values illustrated, the amount of oxygen extracted from the red blood cells of a non-anemic person is practically the same as that taken up from fewer red blood cells under acute normal volemic anemia. The first mechanism results from the decreased blood viscosity and sympathetic stimulation. The second mechanism results from a redistribution of blood flow to areas of high metabolic demand and from improved microcirculation.
I am really convinced that a better knowledge of the mechanism allowing the maintenance of adequate tissue oxygenation during acute normovolemic anemia could decrease the risk of blood transfusion.
What does experience with this principle alone reveal?
I halved our transfusion rate by simply saying, could we lower our triggers from 10 to 8? And just taking a little more control over the decision. That was very easy. That cost nothing.
We do know that we can allow patients to equilibrate to relatively low hemoglobin levels without blood transfusions.
Obviously, it is important to plan ahead, especially if the patient, for religious or other reasons, refuses allogeneic blood. Preoperative planning requires a careful clinical assessment of the bleeding risks and a thorough laboratory screening, including standard hematological parameters. Based on the patient's condition, this may include other tests, such as a coagulation profile and tests for conditions contributing to anemia. Next, there is the need to calculate the safety zone or tolerable red blood cell loss for a particular patient throughout perioperative care. Here is how Professor Earnshaw explains his approach using the example of joint replacement.
All you need is height and weight, male or female, initial hemoglobin, hematocrit, and you can immediately work out what their blood volume is. Next, either using your personal data, and anybody who's doing more than a few joint replacements should be able to go back and look what their typical loss is. So you want to know what loss there will be for that particular procedure. And the only other thing you need to know is how much can you tolerate? In other words, how low can you let this patient go?
What if the expected RBC loss is greater than the tolerable?
You can increase the blood loss that is tolerated by the patient by simply lowering the threshold of transfusion trigger. Or you can increase the allowable blood loss by increasing the initial hematocrit of the patient, and therefore have the patient start or go into the operation with a higher mass of red blood cells.
Several of these proactive techniques can be grouped under the second pillar, optimizing RBC mass.
We can expand the circulating red blood cell mass of the patient before the operation. And this can be achieved with cheap hematinics like iron, folic acid, vitamin B12.
For selected cases, recombinant erythropoietin, or EPO, combined with iron therapy can be used to treat anemia or to raise the pre-surgical hematocrit to within a range of 45 to 50%. EPO is normally started 10 to 21 days prior to surgery. EPO, illustrated by small particles, increases red cell production by affecting the survival, differentiation, and maturation of erythroid cells in the bone marrow. In the late erythroblastic stage, the nuclei are expelled. Finally, the erythrocytes are pushed into the bloodstream. Note the acceleration of red cell production with EPO. Besides the increase in RBC mass, under EPO treatment, usually 1 week is gained. Note the comparatively higher hematocrit rise under EPO therapy, according to one study.
And utilizing erythropoietin, we can increase the circulating hemoglobin by 1 gram deciliter for each week of treatment.
Recombinant human erythropoietin therapy is a tool that has also been shown to be effective as a blood conservation strategy. It's been shown particularly in orthopedic procedures in patients who are anemic. And by that I mean whose initial hemoglobin is less than 13 or hematocrit is less than 39%.
Now we use erythropoietin in very specific cases, like for instance also the children of Jehovah's Witnesses, where we start to administer this medication 4 to 6 weeks before the operation. It's given twice a week with a dosage of 400 units per kilogram.
If you combine the two principles, that is, increasing the preoperative hematocrit and decreasing the threshold for allogeneic blood transfusion, then you can allow an even larger blood loss to occur without the need for allogeneic blood transfusion. Now, this allowable blood loss can be further reduced, certainly, by surgical techniques or by anesthesiological techniques.
Thus, even such complex procedures as spinal surgery and redo open heart surgery are routinely performed with an even wider safety zone afforded by the third pillar of a transfusion alternative protocol, either by minimizing the bleeding or by recovering shed blood. Let's consider several important intraoperative techniques. Patient positioning is a simple, cost-effective technique to reduce bleeding. Local venous pressure changes depending on the field's position relative to the heart, and lower pressure directly correlates with blood saved.
It's important to position the patient properly during orthopedic surgery. In my experience, it makes a big difference in spinal surgery.
With pressure on the abdomen, and thus on the paravertebral veins, blood loss increases. With proper support, avoiding abdominal compression, blood loss decreases. Another option to decrease venous pressure in some surgeries is to use regional instead of general anesthesia, as shown here prior to a cesarean section. A further technique is the maintenance of normothermia, especially during long operations.
So if a patient is cool or cold by 1 or 2 degrees temperature, you are seeing a loss in ability of platelets and coagulation factors to work. So it's essential that we keep the patients normothermic.
Normothermia is extremely important. And therefore, our operating theater temperature is 27 degrees in those major procedures, which sometimes is hard for the surgeons, even for the anesthesiologists, but it's very good for the patient.
More directly, the patient's body can be warmed with a thermal suit or blankets. There are even simple machines to warm fluids before infusion. Next, hemodilution.
The principles of hemodilution in terms of reduction of blood loss are really quite simple. If blood is removed from the patient immediately prior to or immediately after induction of anesthesia and replaced with acellular fluids, then when the patient bleeds intraoperatively, the red cell loss is less.
For every 100 mLs of whole blood lost by the patient, in the case of a patient with a hematocrit of 27%, they're going to lose 27 mLs of RBCs rather than the 45 mLs of RBCs they would have lost had we started the case at a hematocrit of 45%.
Additionally, the hemodilution procedure is acceptable to a number of Jehovah's Witnesses.
Hemodilution is certainly cost-effective, but not only that, it is also beneficial for the patient, as it improves blood rheology, as has been shown by many studies.
Another transfusion alternative technique for selected surgeries is induced hypotension to lower mean arterial pressure intraoperatively. Usually a drug is used to decrease systemic vascular resistance. This typically prevents up to 50% of blood loss. Anesthesiologists urge caution when combining hypotension with hemodilution because hypotension can interfere with the normal redistribution of blood flow. A crucial factor that requires skill and patience is meticulous surgical hemostasis and technique.
Take your time and not my blood.
I teach the residents to just gently score the skin and open it, and then use the cautery to get all the blood vessels.
The basic technique for a surgeon to control bleeding is to ligate the vessels. That's true for all the vessels, let's say, down to 1 millimeter in diameter. If there's some bleeding persisting, there are coagulation techniques, best of which is, at the moment, argon beam coagulation. We use it routinely in liver transplantation.
Hemostatic agents can also assist.
There is 2 types of agents. General agents that could be administered intravenously, such as tranexamic acid or aprocitenine. And the surgeons have also the possibility to use topical glues in order to better control the bleeding in the surgical field.
Here, a fibrin glue pad is directly applied to the dissected surface of a liver. This product, containing a blood fraction, is accepted by a number of Jehovah's Witnesses and others. The final intraoperative transfusion alternative is called cell salvage. If intraoperative bleeding becomes heavy, a cell salvage machine, often kept on standby, is able to recover the shed blood. As the blood flows through the device, some machines simply filter out any debris, while other types include the additional step of washing the red cells as they circulate. A cell salvage machine can save up to 50% of the blood that would otherwise be lost. Such devices are acceptable to a number of patients who are Jehovah's Witnesses.
Cell salvage is a very important technique because when you use cell salvage, the blood lost by the surgeon is not lost for the patient. Cell salvage is usually used when you expect the blood loss in the range of 1 liter and more for an adult patient.
Perioperative blood salvage is a very useful technique for blood conservation because it's very easy to organize in the majority of operations. Cardiovascular, orthopedic, gynecological, and so on. So it can be widely applied in surgery.
Some machines allow cell salvage on a small child, expanding the horizons of the technique. Often, simple cell salvage machines are also very valuable in the post-operative setting.
What we tend to do, particularly for knees, where it's often done with a tourniquet and there is no intraoperative loss, we salvage it immediately afterwards. It's very simple and very useful and moderately cheap. Just the stuff that comes out, filter it and give it back. And we've been doing that here now for about 4 years, and we're very pleased with the success rate.
Another important consideration for minimizing blood loss is the use of microsampling for necessary tests. Microsampling is critical in both preoperative and postoperative care of infants and anemic adults. Professor Michael Obladen addresses the challenge presented by premature infants.
It helps teaching the doctor the amount of blood really required and not to take more. Formerly it was, if in doubt, take half a milliliter more. And we don't speak about milliliters anymore, we speak about microliters. The whole process of sampling is documented in the baby's chart so that everyone is aware about the cumulative amount of blood withdrawn.
Professor Ernest Moore on microsampling adults.
If you add up the blood samples, it's remarkable how much is taken off in a week of the ICU care. So certainly, using microtubule type of analysis, we can markedly reduce the number of cc's of blood lost today for sampling.
Physicians who advocate transfusion alternative strategies are often asked if these same strategies are applicable to trauma or emergency care.
When you're looking at principles in patients who have trauma or massive unanticipated blood loss, is first and foremost, act quickly. The cessation of bleeding, whether surgically or in other means, must be the first principle. The second one is that one can apply these modalities, such as cell salvage, on the specific circumstances and recoup the patient's own blood.
The anesthesiological concept are to tolerate a certain degree of relatively low blood pressure and to be a little restrictive in infusing enormous amounts of volume, particularly before a surgical source control has been achieved. That means before the surgical bleedings have been identified and stopped.
Perhaps one of the, I think, greatest advances in conserving blood in trauma has been the concept of so-called damage control surgery. That is, once we open the patient's abdomen or chest and note that the patient is unable to coagulate, that we address the major bleeding vessels, then control the surface with pads and close the patient temporarily, allowing them to be taken to the intensive care unit where their resuscitation is continued, and efforts to reverse those adverse effects on coagulation like hypothermia are specifically addressed.
In trauma management, rewarming is very important because during advanced hypothermia, blood coagulation doesn't function properly and therefore the blood loss is larger.
Professor Moore reviews additional effective steps.
As you move into the intensive care unit in the more complex problems, then I think the use of erythropoietin becomes even more compelling in the trauma patient. In Jehovah's Witness patient, we have no delay in providing both erythropoietin and iron immediately after they arrive in the hospital. We may in fact do preemptive interventional radiologic evaluation of solid organs and embolize arteries that are not currently bleeding actively but are at risk for bleeding later.
This brief overview of strategies is properly viewed as a comprehensive concept.
To say there's a list of transfusion alternatives is correct, but that really does not get to the heart of the issue, and that is that we must use those alternatives in multiple combinations, focused on the patient.
Not everyone needs every strategy, the erythropoietin being a very good example of that.
Dr. Todd Rosengart has published 2 major studies on multimodality blood conservation in coronary artery bypass operations performed without allogeneic transfusion.
When we looked at a series of 50 Jehovah's Witness patients and 100 patients in the general population, we found a shorter length of stay and a lower cost using our blood conservation strategy.
Medicine gives every indication of rapid advancement in this new millennium. In the meantime,
I think all physicians should be interested in blood conservation strategies because there's substantial evidence that reductions in morbidity and mortality and reductions in cost can come with these strategies.
The less blood that is transfused in a given surgical program could be used as an index of the quality of that program.
I think that the safest transfusion is the transfusion never given.
And blood conservation is a very simple method which makes things rather smooth, less expensive, and with a better outlook for the patient.
I think there are some very simple, very cheap things you can do which would help the majority of people, and this could be done in the smallest of hospitals.
Transfusion alternatives are safe. This is not just something I use for the Jehovah's Witness patient, for example. I use this for every patient who comes to me. Transfusion alternatives clearly are good medical practice, sound medical practice, safe practice for our patients.
Dorothy McPhee has a life-threatening medical problem, an artery that could burst at any time.
The normal way of doing this operation is generally through the abdomen, a long vertical incision.
Leslie is a young girl with a serious spinal deformity.
The patient is a Jehovah's Witness, and in a procedure of this magnitude, it is unavoidable that some blood loss will occur.
Both patients need surgery. Yet both patients have religious beliefs that preclude their accepting a blood transfusion. Medical science is now providing doctors with alternative strategies to treat successfully patients who, for various reasons, avoid blood transfusions. These new strategies may soon benefit all patients. At the dawn of the 21st century, society is becoming increasingly diverse. People everywhere are being exposed to different languages, customs, cultures, and religious beliefs. Adapting to these differences is a challenge to all strata of human society. It is a singular challenge for the medical community.
We're living in a pluralistic society, and the doctor has one set of values, but he or she will meet patients who have their own values and their own position about certain issues.
There's a lot of different cultures out there, and they have entities specific to their own cultures that we as healthcare workers need to understand.
I think the duty of physician is not simply to preserve life, but the first and foremost duty of physician is to respect the patient.
In the past, the medical profession found it difficult at times to respect the healthcare needs of one religious group in particular, Jehovah's Witnesses. This was because of their avoidance of blood transfusions.
That was the easiest decision.
because there was under no circumstances would I accept blood.
One thing I heard, he says blood transfusion. And immediately I said, no, no.
I couldn't live with myself if I turned my back on my beliefs and my God, and I wasn't going to accept a blood transfusion.
Their abstaining from blood transfusions was often misunderstood by the public.
There was certainly a time in years back where Jehovah's Witnesses were looked at by physicians and especially surgeons in a negative way.
I think before I had ever met a Jehovah's Witness, I had a certain mindset that they were maybe a religious fanatic type person.
Part of it, I'm sure, is prejudice about a religious sect which the physician or the judge or the lawyer, about which they may know next to nothing.
A lot of people nowadays have heard of dangers or diseases that might be contracted from blood and blood transfusions. But frankly, for Jehovah's Witnesses, central to their avoiding blood transfusions is because the Bible highlights the preciousness of blood.
It's a very clear statement, by the way. It isn't something that takes a lot of theological study to determine or work out. It says very plainly in the Christian scriptures, abstain from blood.
From the point of view of someone who's not a believer, this seems an irrational act.
For some people, it seems to be anti-medicine. It seems to be somehow putting the patient in jeopardy.
I think some of us, myself included, was under the impression that maybe Jehovah's Witnesses didn't want the best medical treatment, that they were sort of against medical care.
There's no question it mattered to me whether she lived or died. I brought her to the hospital in the first place to help her recover.
I didn't want to just die, and I don't think anybody wants that to happen.
It's not some sort of a suicide pact that they want to enter into with you. They want to live, they want to have good health care, and I think that you can work with them.
I realized they wanted the best medical care, but they just wanted it without blood.
I think the effort has to be made to remove the perception that Jehovah's Witnesses are somehow in a category by themselves.
Clearly, you can point to many religions. They all have one issue or another, which you may or may not agree, but that's not the issue.
That this is a religious precept. This is not illogical stubbornness. This is a religious belief. And just as I respect the religious beliefs of many other religions, I think I have to respect that.
All patients, as a general rule, have the right to receive treatment or to refuse to receive that treatment after they've had full, open, and candid discussion with the treating physician.
I believe the basic element of patient's right is the right of self-determination. That is the right of any patient to decide what shall be done with his or her own body.
Patient rights notwithstanding, some have claimed that declining what they consider life-saving medical treatment is irrational.
I think it's wrong to equate a refusal of a treatment with suicide, which is a conscious choice to end one's life.
There is always a legitimate question about a patient's competence, but just the mere refusal of blood in itself is not any kind of such indication.
I don't believe that refusal of treatment is irresponsible or irrational. I think that just because one person chooses to not take this pill or that fluid or this kind of solution is their own personal choices.
We have patients who say they don't want to be on a mechanical ventilator, they don't want a breathing tube.
It's an everyday event for a patient who has malignancy, a cancer, to refuse some treatment or other. They don't want to have chemotherapy, they don't want to have radical surgery. So the idea that patients refuse treatment is something that I work with, don't take as a personal insult.
These facts are often obscured by news stories claiming that someone died because he refused a blood transfusion.
To say that one has died because of refusal of blood, I think, is a very general, misleading statement.
That's an oversimplification of the tragic event.
It's rarely, if ever, the case that a patient refused a blood transfusion and therefore died.
People die because of either a medical disease or a consequence of trauma or surgery where there's been complications.
I can tell you, I have done over 200 Jehovah's Witness patients. I have never lost a patient because I could not give the patient blood.
Why then does blood transfusion remain the standard treatment for serious blood loss?
I think that physicians have been brought up with the idea that blood is the gift of life and that inherently blood is good for you.
The refusal to accept a blood transfusion bothers and concerns many physicians because they're worried that without the transfusion, the well-being of the patient is jeopardized.
To appreciate fully why physicians feel this way, one needs to understand a little about blood and why transfusions are given. Blood circulates through the body by means of an amazingly intricate system of conduits called veins and arteries. Arteries carry oxygenated blood away from the heart, eventually branching into tiny vessels called capillaries. These deliver the oxygen-rich red blood cells to every part of the body. Nutrients and oxygen are exchanged for carbon dioxide and other wastes at the cellular level. Veins then transport the oxygen-depleted blood back to the heart, which pumps it to the lungs. There, the carbon dioxide is exchanged for oxygen, and the cycle begins anew. This cycle is absolutely essential to life.
If there's no blood to bring the oxygen to the cells die, the body dies.
When someone suffers severe blood loss, doctors have two urgent priorities.
The most critical immediate need is to stop the bleeding.
Everything takes backseat to stopping the bleeding.
And number two is to restore the volume within your system.
What can happen when a patient loses too much blood volume?
Then you don't deliver blood to the brain or to other organs and a person can die.
And what you need to do is restore volume, restore perfusion, and restore oxygenation.
A way of correcting that decrease in blood volume is by giving other fluids intravenously. This can be done using any one of a number of fluid types and doesn't necessarily require blood.
Increasing numbers of patients are opting to avoid blood transfusions for personal reasons.
If you've ever had a conversation with a patient the night before surgery and you were to ask them if they had a preference, would they prefer to avoid a blood transfusion, the answer is always yes.
I would say that today at least 80% of the patients would strongly favor not to have blood transfusions.
Blood transfusion, traditionally considered a normal adjunct to surgery, presently is considered something that has to be avoided.
I mean, there are real risks as far as transfusions are concerned.
There are concerns about bloodborne pathogens and certainly the concern about AIDS.
It's a biological product. It can have diseases, etc. We screen for most of them, but there are some there that we just don't know about.
We've certainly seen some horrendous new diseases in the form of HIV, come along that probably didn't exist in the past. Whether the next disease will come along in 10 weeks, in 10 years, or 100 years, nobody can say.
We have hepatitis C, hepatitis B that are transmitted, and the social costs of that are very high.
There are transfusion reactions that occur. They're very rare, but they can be potentially dangerous or even life-threatening.
We can mix the blood up and cause catastrophe. Patients have died and do die from getting the wrong blood.
It is interesting to realize now in the late 90s or early 2000 that the blood transfusion to a certain extent does not do what we always use blood transfusion for.
We have become persuaded over the years that many of the bad things that happen to patients after surgery are in fact not bad luck, are not lack of surgical skill, but are in fact the complications of transfusion.
These concerns have spurred the development of a wide range of alternative strategies, treatments that are acceptable to many of Jehovah's Witnesses and others who also choose to avoid blood transfusions. Alternative strategies can be grouped around 4 organizing principles.
That involves anesthetic factors, it involves the use of certain substances, and it certainly involves also the surgical technique.
The most important technique to control bleeding is to avoid bleeding. That with less bleeding during surgery, the result at the end is better and the outcome is more likely to be smooth.
Careful surgery means preventing blood loss. Age is no factor. We have operated on newborns, we have operated on people in their 90s.
A surgeon who operates without losing large amount of blood is almost invariably a good and careful surgeon. One who loses large amounts of blood is most often the reverse.
A variety of instruments are now available to help surgeons minimize bleeding.
There are strategies for intraoperatively using electrocautery instead of scalpels.
If there's some bleeding persisting, there are coagulation techniques, best of which is at the moment argon beam coagulation.
There are non-invasive tools that enable the surgeon to see inside the body, minimizing surgical incisions.
You can use drugs, a topical application of different products that will help prevent blood loss.
We have now several methods available, like the fibrin glue.
Fibrin glue, made from blood fractions, stimulates coagulation upon contact.
The fibrin tissue adhesive is certainly very, very useful because it does not harm the tissue.
In a Jehovah's Witness, where blood loss is so critical, I think that you have to be very extremely meticulous not to lose even a drop of blood.
There are new technologies of hemodilution and reinfusion that make the operation easier and which are acceptable to people who have a religious precept against blood transfusions.
The principles of hemodilution in terms of reduction of blood loss are really quite simple.
Basically, we do a closed circuit on the patient. We draw off blood from the patient, keep it in contact with the patient, and substitute it with fluids.
That results in a diluted blood, and therefore the patient loses only diluted blood rather than native or concentrated blood.
When the patient bleeds intraoperatively, the red cell loss is less.
It would be like taking a quart of milk and adding water, so you have 3 gallons of it now, but the original quart is still in there. But if you were to spill it into something, it would be a lot of water and a fraction of the milk. And then at the end, you get rid of the water, and then you're back to where you started.
And we use that routinely in this institution, especially for those patients who have anticipated a significant blood loss.
I think that's probably nowadays, besides not just for Jehovah's Witnesses, a pretty good standard of care for large volume loss surgery.
If we do lose blood, this is the kind of case where we'll use a cell saver. we'll suction up any blood that's lost. We wash it, we clean it, we process it, we filter it, and then we'll give it back to you.
Cell salvage is a very important technique because when you use cell salvage, the blood lost by the surgeon is not lost for the patient.
In any trauma patient with a significant blood loss, I would always prepare the cell saver system.
A key element in stimulating the body's ability to replenish its own blood supply is a hormone called erythropoietin.
Erythropoietin is a natural substance. It is formed in the kidneys, other organs as well, but primarily the kidney, to help our bone marrows form the red blood cells that are going to carry our oxygen.
Blood cell production takes place primarily in the sternum, the ribs, the vertebrae, and the pelvis. Recombinant erythropoietin boosts the body's natural production of red blood cells.
So if I know the patient's going to be in the hospital a long time, I may start them on some recombinant erythropoietin so that they can start building up their own blood stores.
This can be a very cost-effective strategy to reduce the utilization of allogeneic blood transfusion.
One of the most exciting things about this whole field in transfusion alternatives is that the majority of things that we talk about are within the reach of physicians and hospitals around the world.
There are now available techniques in almost every subspecialty of surgery and medicine that allow bloodless treatment.
Alternatives, like any other therapy, are not necessarily free from risk. So a patient, a witness patient in particular, may want to become informed about the benefits and the risks that are associated with any particular treatment.
They should be a prudent consumer.
How effective are these alternative strategies in helping doctors treat patients who do not want blood transfusions? Leslie Lax had just begun elementary school when it became apparent that she had a degenerating spinal deformity. Doctors diagnosed Leslie's condition as a severe form of scoliosis.
Scoliosis is a curvature of the spine, so we have to correct it as much as the spine flexibility allows us.
After a brace failed to correct her condition, doctors recommended an extensive surgical procedure.
We use essentially a series of hooks and metal rods made out of stainless steel that are implanted in the patient's back and used to essentially distract the spine and achieve alignment.
The Lax wanted the surgery performed without a blood transfusion, so they found a surgical team that had experience using bloodless techniques. Before the surgery, Leslie's doctors boosted her blood through the use of iron and recombinant erythropoietin.
So it was essential that we do the surgery without excessive blood loss. The way that we were able to achieve this is using two techniques, basically. One of them is what's called the cell saver. The other technique we used is called hemodilution. It is safer in that it is the patient's own blood and it has remained in continuous circulation with the patient, so there's no chance for contamination or blood-transmitted diseases.
The surgery was a success and no blood transfusion was administered. Within days, Leslie was up and walking.
She's so happy. She can be able to stand. She always say, "Mommy, I'm almost as tall as you now."
Although Leslie will have to wear a brace for a while, doctors are confident she will lead a normal life.
I would like to skate and skateboard, maybe learn how to snowboard and stuff like that.
Sometimes alternative strategies involve new surgical techniques to reduce blood loss in patients that don't want a transfusion. 75-year-old Dorothy McPhee suffered an abdominal aortic aneurysm, a life-threatening condition that traditionally requires extensive surgery.
The normal way of doing this operation is generally through the abdomen, a long vertical incision from the lower chest down to the pubic area, having to work around and behind the entire intestinal tract, hospitalization ranging at best days, 4 or 5 days, to an average of a week or even more, presuming there are no operative complications.
Since Dorothy is one of Jehovah's Witnesses, her physicians used a surgical technique that minimizes bleeding.
What we did today is called endovascular aortic surgery. Specifically, endovascular meaning we're working within the artery. Through that artery, we place our catheters, our wires, all the instruments that we steer right up into where the aneurysm is. And then we can visualize the aneurysm by doing fluoroscopy, X-ray technology.
Dorothy's surgeons inserted a wire mesh called a stent and were thus able to repair her aorta without a large surgical incision that would have caused a lot of bleeding.
Small incision in the groin, all the manipulations through that, a virtually pain-free, complication-free post-operative course, home generally 24 hours. So everybody's a winner.
I feel fine. I never would have believed it, but I do.
2 days after her surgery, Dorothy was sent home. She recovered nicely. A growing number of healthcare providers are willing to meet the challenge of treating patients who avoid blood transfusions.
With the development of all those techniques, there's nothing really specific about Jehovah's Witnesses anymore. We know that they don't want blood transfusion, and we have the technology to follow their wish.
The belief that you don't want a blood transfusion should not in any way, that should be a tiny part of the whole medical care environment. That should be acknowledged, be put over to the side, fine. Now's the other 99% of your care.
I guess it could be likened to a patient who is allergic to penicillin. You wouldn't expect the physician to say, well, I'm sorry, I can't treat you because I can't administer penicillin. No. He simply says, we'll give you a medical alternative. We'll give you another antibiotic. And he gets on with treating the patient.
Hello, it was a theoretical doctrine.
This enlightened approach to patient care has exciting implications for the public at large.
The fact that we couldn't use blood in Jehovah's Witness, we learned how we didn't have to use blood in many, many other situations. So it has actually propelled us in the right direction.
Transfusion alternatives clearly are good medical practice, sound medical practice, safe practice for our patients.
Indeed, it is a standard that should be available to all patients.
What we're talking about here is going to be a moot point, because bloodless medicine and surgery will become, in the next 5 to 10 years, so widespread that it won't be novel anymore.
Jehovah's Witnesses have had the unique privilege, because of their religious position in the matter, of helping doctors to learn better ways to treat patients without subjecting them to the risks of blood transfusions.
What I have seen in my own experience is that they have turned the medical profession around to the point where the gold standard of treatment frequently now is to treat people without blood.
Already, some 100,000 physicians worldwide are making bloodless medicine and surgery available to any patient who does not want a blood transfusion. Many experts agree that in the near future, medicine and surgery without the use of blood transfusions will be the standard of care for all patients.
There are now available techniques in almost every subspecialty of surgery and medicine that allow bloodless treatment. that we are getting away from blood transfusions in general.
As a heart surgeon, it's unusual for the guy not to like blood. You should love blood, but I don't. I'm very proud when my patient comes out of the operating room, has not received any transfusion.
I can see within the next few years us getting to a point where we do not have to even think about giving blood.
Bloodlust and genocide image for the year 2010. Purim fell on February 28th through March 1st. In this image, the Yenta Madonna and Guy Ritchie can be seen dressed up in festive costumes for a Purim celebration of genocide with her local Kabbalah friends. The Jewish media often portrays this as just an innocent, harmless Jewish Halloween, but humans don't drink blood and ritually slaughter babies for Halloween. Purim parades itself as an innocent celebration and a necessary part of Jewish religion. The truth is, the so-called Jewish religion is nothing more than a sick, twisted ideology that condones and promotes Jewish hatred for non-Jews, supremacism, racism, elitism, murder, genocide, rape, pedophilia, subversion, deceit, usury, and all the other ills Jews were once very commonly known for in almost every country on earth. If you doubt this, go watch the 1940 movie Jud Suslink and have a look at how society really saw the Jews, who have always behaved as intrusive, destructive, murderous parasites. This movie wasn't Nazi propaganda, as a Jew writer at the New Yorker just tried to say here link, while sliding Subverted Nation as an anti-Semitic website. Nice of them to mention me, but the way he tries to make the subversive nation-wrecking, murderous, rapist Jew Oppenheimer look like a victim is just plain rotten. So, what about Purim? What is it? To put it simply, Purim is a festival held annually on the 14th of the Hebrew month Adar, because supremacist Jews don't even use the same calendar as we do. In human terms, the holiday usually falls around February or March, with Passover following a month later. During this time of Purim, Jews celebrate the mythical slaughter of 75,000 of their enemies, i.e. genocide. Image link here. A couple Jews are dressed up for their celebration of Purim in Israel. Can you tell which one is the real female? Or are both of them men? No doubt they would carry along an American-made assault rifle, just in case a Palestinian might need to be offered up as a sacrifice. The Jews celebrate the mass murder of their enemies, on the pretext that these enemies of the Jews are just evil people, who deserve to be viciously murdered in cold blood, but that couldn't be farther from the truth. Historically, the enemies of the Jews have been all of your ancestors, for those of you who are non-Jewish. Historically, the enemy of the Jew has been the hard-working, ethical, human beings with a conscience, which makes us completely alien to Jews. For Jews, conscience and compassion do not exist. They are merely traits of ours that they mimic so that they might manipulate us. In fact, almost all of the behavior of Jews today is a mimicry of our own behavior. Behind closed doors, or out of sight of non-Jewish goyim, cattle, as they call us, it is a whole different story. Look at the story of Purim as Chabad Jews, some of the most vile Jews, describe it here link. The Persian Empire of the 4th century BCE extended over 127 lands, and all the Jews were its subjects. When King Ahasuerus had his wife, Queen Vashti, executed for failing to follow his orders, he orchestrated a beauty pageant to find a new queen. A Jewish girl, Esther, found favor in his eyes and became the new queen, though she refused to divulge the identity of her nationality. Meanwhile, the anti-Semitic Haman was appointed prime minister of the empire. Mordecai, the leader of the Jews, and Esther's cousin, defied the king's orders and refused to bow to Haman. Haman was incensed and convinced the king to issue a decree ordering the extermination of all the Jews on the 13th of Adar, a date chosen by a lottery Haman made. Mordecai galvanized all the Jews, convincing them to repent, fast and pray to GD. Meanwhile, Esther asked the king and Haman to join her for a feast. At the feast, Esther revealed to the king her Jewish identity. Haman was hanged, Mordecai was appointed prime minister in his stead, and a new decree was issued granting the Jews the right to defend themselves against their enemies. On the 13th of Adar the Jews mobilized and killed many of their enemies. On the 14th of Adar they rested and celebrated. Image link. This terrorist Jew murderer walked into a mosque during Purim with grenades and an M16 and started slaughtering Muslim worshippers. Luckily, this pathetic wretch was stopped and beaten to death with fire extinguishers. This is how all Jews should be dealt with. Basically, a Jewess weaseled her way into the king's favor, much like Oppenheimer in the movie Judd Sus. She hid her identity, because up until just this last century, the entire world was well aware of the dangers that Jews posed to sane people, and humanity as a whole. The righteous Haman did as many of us have done today. Declared that all Jews should be exterminated for their crimes against our peoples, and their refusal to stop their destructive, murderous, treasonous, and subversive behavior. Unfortunately, the Jews are good at using sex, greed, and lust to undermine many people's ability to think clearly. Since Esther, a Jewess, had now slithered in and made herself the object of the king's desire, she would wield this influence to have Haman killed for the decree he ordered. Don't be fooled, because Jews do not believe in or pray to a god, as stated above, or they wouldn't have such a problem spelling the word God, which they substitute GD for. Whatever they pray to is a dark, demonic force of evil energy, to which they also sacrifice human babies to. After using her influence to stop Haman from righteously having Jews exterminated, Esther used her sexual and emotional pull with the king to have Haman executed instead. Then the Jews mobilized and murdered 75,000 people, to stifle any real opposition to their machinations. Haman's 10 sons were also executed by hanging, taking this despicable story down in morality another notch. Again, this story is a fable, but that doesn't stop Jews from enjoying their feast of genocide. The Jews celebrate this holiday with great passion, and great fanfare. Here's more of what they do on Purim. A. Reading of the Megillah, Book of Esther, which recounts the story of the Purim miracle. B. Giving money gifts to the poor. C. Sending gifts of food to friends. D. A festive Purim feast. It is also customary for children to dress up in disguising costumes. So, the Jews ensure they read the story of slaughtering their enemies during this holiday to keep the thought of genocide against non-Jews at the forefront of this murderous celebration. Next, they give gifts of money to poor Jews, so that they might rise up to positions of power and influence over non-Jews, and the kids dress up like the goblins that they are, before they enjoy their feast of bloodlust. You can click here link to see the story of Barak Goldstein, who walked into a Muslim mosque during Purim with grenades and an American-made M16 rifle, and started slaughtering Muslims as part of his celebration. This is not the only murder by Jews coinciding with Purim, but the telling part is how Jews erected a shrine to this murderer in Israel, and now hold him to be a hero and a martyr. How many other cultures purposely celebrate murderous terrorists like Goldstein? No matter how pathetic they sound, don't dare show pity for the Jew. They have none for you or the people they murder for these festive events. Image link. Purim snacks include hamantashen or Haman's ears, treats fashioned to look like human body parts, which are often made with dried human blood. You still want these pathetic creatures hanging around your country? How many other cultures can you really find evidence of people celebrating genocide and terrorism, besides the Jews? The answer is none, but this is a real-life example of Jewish mass murder on Purim, and Jews celebrating said murders. One couldn't ask for a better illustration, but the world could certainly ask to do without Jews, so that we wouldn't have to experience these murders to begin with. The Jews send gifts of food to each other, but what kind of food? You will find it interesting to note that on Purim, Jews celebrate by sharing a special treat called hamantashen. This name is purposely distorted by Jews, because in Yiddish it means Haman's pockets, but it turns out there is another term for this treat that espouses a more truthful definition of this so-called treat. The treat is actually called Oznei Haman in Hebrew, meaning Haman's ears. Check it out here link. That's right, on Purim Jews celebrate by giving each other gift baskets containing a treat that is meant to represent human body parts, while celebrating the murder of 75,000 of their enemies. Is the picture starting to become clear yet? Well, if you believe the Jew at the New Yorker, this website is merely anti-Semitic and therefore shouldn't even be read at all. You're lucky you made it this far. Here link is even more tasty snacks to tease Jews with an appetite for human flesh. Purim foods don't end with just cookies. Kveos de Haman, meaning Haman's hair, is a noodle dish tossed with a lemon sauce. And Kilat Sher is an oversized challah made to represent the ropes that killed Haman. Purim merely seems to fulfill the need Jews have for fantasies of genocide and rivers of blood. The Jews enjoy slaying their enemies by the thousands, and they have even far surpassed this by slaughtering millions upon millions of people in real life. The Jews also know that most of you do not know about any of this, and it's Jews like the one at the New Yorker who work tirelessly to make sure that you never do. Now that we've determined how vile the premise behind Purim is, You might rightly wish to ask, how important is this murderous feast to the Jews? Well, it turns out that it's important enough for Jews to forfeit a playoff game for their yeshiva high school girls basketball team, as evidenced here link. These next-generation Jewish racists first tried to have the game rescheduled, so that they wouldn't have to miss their celebration of murdering Goyim or their playoff game. Image link. Look at the smirks on the faces of these Jewesses as they shake the hands of their bewildered non-Jewish, Goyim, opponents. It's as if their faces are saying, "We will feast on your blood rather than play games with you, silly Goy." These supremacist little beasts wanted the whole playoff schedule altered to suit their genocidal festival. When that didn't work as planned, these murderous little demons decided it best not to play, with the excuse that they will be fasting before they celebrate genocide of the human cattle, Goyim, meaning they wouldn't be able to have water during their game play. To these Jews, it's far more important to party it up to rivers of blood and sacrifice, than it is to play a ball game with the cattle used for slaughter. The article states, the school did make an attempt to play, but only if the Goyim, ignorant of their genocidal feast, would change the whole damn schedule to suit the supremacist Jews. In the end, the little Jewesses showed up on the basketball court to forfeit their game, so that they may not forfeit their putrid holiday of hate and murder against non-Jews. There is no doubt, the little girls who shook their hands on the court that day, had no idea what the real reason was that these ghouls wouldn't play. In fact, they probably thought it was a godly religious devotion that kept these beasts from dribbling basketballs with them, but that couldn't be further from the truth. The dribbling of human blood down their disgusting faces is far more important to these Jewesses. This truth is such a polar opposite that the brainwashed children from the public schools would gasp at the sound of it, and cover their ears as if hearing it alone could make their ears bleed. Yes indeed, because on Purim, not only do Jews celebrate genocide and murder, but as demonstrated with Baruch Goldstein, they often engage in mass murder and ritual murder of non-Jews for Purim. Many don't realize that the invasion of Iraq in 2003 was interestingly announced by George Bush during Purim that year. You can see here link. His speech was given during Purim 2003, March 1819. Image link. The announcement of the invasion of Iraq and the bombing of Saddam's palace were timed to coincide with the Purim holiday of 2003. Is this bloody enough to appease whatever demon Jews sacrifice humans to? Subsequently, over 1 million Iraqis have been murdered and mutilated by depleted uranium, Apache gunships, M1 Abrams tanks, and thousands of U.S. soldiers. Many thousands of these soldiers have also lost their lives, carrying out the Purim-initiated war against the Middle East, which has now spread from Iraq and Afghanistan to Pakistan, Yemen, and beyond. You can even look here link on Wikipedia and see that the invasion was preceded by an airstrike on the Iraqi presidential palace on March 19, 2003, making sure their attacks would coincide with their murderous Purim holiday. Now that we've established Purim as a genocide festival, let's take a look at another interesting, and much more important aspect that goes along with Purim, ritual murder. It seems the Jews have a thing for slicing and dicing humans, drying their blood, and eating it in some of the snacks mentioned above, shaped like human body parts. At first that might sound silly, until you realize that almost every country that exiled the Jews, counted ritual murder of non-Jews among the many reasons for doing so. After 84 countries go through this, you don't want to sound ridiculous trying to write it off as vicious libel, but the vicious barbaric Jew has no problem using the media to write it all off as mere slander. Many people have heard the term blood libel, and I assure you, this is not merely an anti-Semitic slander. This is something that has been thoroughly documented throughout history. In fact, it seems all throughout history are cases of ritual murder associated with Purim. Have a look at what Arnold Lees said in his book on Jewish ritual murder here link. This feast is often celebrated by an exhibition of gluttony, intoxication, and curses on the memory of Haman, and even to this day in London, the Jewish bakers make cakes in the shape of human ears which are eaten by the Jews on this day, and are called Haman's ears, revealing once again the inherent hate and barbarism of the Jew in our midst. The two principal feast days associated with ritual murder have been 1. Purim, and 2. Passover, the latter at Easter and the former about 1 month before it. When a ritual murder occurred at Purim, it was usually that of an adult Christian who was murdered for his blood. It is said that the blood was dried and the powder mixed into triangular cakes for eating. It is possible that the dried blood of a Purim murder might sometimes be used for the following Passover. When a ritual murder was done at Passover, it was usually that of a child under 7 years old, as perfect a specimen as possible, who was not only bled white, but crucified, sometimes circumcised and crowned with thorns, tortured, beaten, stabbed, and sometimes finished off by wounding in the side in imitation of the murder of Christ. The blood taken from the child was mixed either in the powdered state or otherwise into the Passover bread. Another festival at which it is thought that ritual murder has sometimes been indulged in is Chanukah, which occurs in December, commemorating the recovery of Jerusalem under the Maccabees in BC 165. Examples of Purim murders are those of Damascus, Rhodes, Xanten-Palna, Gladbeck, and Paderborn. Image link. Isn't it lovely how Jews poke babies full of holes, and drain their blood into a basin, and all that to celebrate the murder of 75,000 non-Jews? Purim is a wonderful festival of hatred, racism, and genocide. It can easily be seen that people have been talking about Jewish ritual murder for centuries. This is but one example. There are literally hundreds of sources of information on known cases of Jewish ritual murder all around the globe. Lisa's book covers a large number of ritual murders of a long period of time. In the book, Lisa even gets it right by attributing this to a racial issue, but seems to muddy the water about what Jews are as a race, confusing things with the Hazar theory among others. That aside, at least he keeps the issue focused on the Jewish race, however he defines it, while laying out tons of undeniable evidence for Jewish ritual murder, and the book is a valuable reference nonetheless. There are other authors covering this topic as well, some of which you can see mentioned here. Link where the ritual murders in Damascus, and many others are covered in fairly good detail. Here is a glimpse of just how many cases there really are to investigate. However, I implore you to do more research on your own if you feel you must. This subject is so far stranger than fiction, you couldn't make it up if you tried. 1750s Algeria, bribe money was used to quash the facts. 1791 Pera, Constantinople helmet scram records the ritual murder of a young Greek child. 1810 Aleppo, Syria, murder of a woman at Easter/Purim time. 1812 Isle of Corfu, 3 Jews were convicted in the murder of 3 children. Monayat in Le crime ritual chez les Juifs says the records were kept in the official archives of the island. 1821 Beirut, Lebanon, an adult Christian male was the victim. 1824 Beirut, Fadila Sayegh, a Muslim, was slain for ritual purposes. 1824 Scram cites yet another child ritual murder case on Corfu. 1826-1827 Antioch, at Easter, 2 Christian boys were ceremonially slain. 1829 Hama, Syria, the Jews of Hama slew a Muslim girl, and subsequently were expelled from the city. 1834 Tripoli, Libya, a Christian Greek fell victim. 1838 Jerusalem, there was an attempt to murder a Muslim for ritual purposes. 1847 Lebanon, Jews were apprehended after murdering a Christian boy. 3 nor were these the last cases to arise in Damascus, another occurring in 1894. The following 2 cases bear most directly on the Damascus murders. 1839 Beirut, Lebanon, both Sir Richard Burton and Arnold Lees mention that inspectors detected a mysterious flask of blood while it passed through the customs house in Beirut. Lees gives the details, a remittance of blood. During the Damascus ritual murder trial, the French consul, Comte de Radimenton, by whose energy and determination the case was brought to light, received a letter from Comte de Soussanet, who wrote, nearly a year ago, a box arrived at the custom house that a Jew came to claim. On being asked to open it, he refused and offered first 100 piastres, then 200, then 300, then 1,000 and at last 10,000 piastres, 2,500 francs. The custom house official persisted, and opened the box, discovering therein a bottle of blood. On asking the Jew for an explanation, the latter said that they had the custom of preserving the blood of their grand rabbis or important men. He was allowed to go, and left for Jerusalem. Comte Radimenton, also French consul for Damascus, later looked for the chief of the custom house, but found that he had died. His successor only vaguely recollected the affair, but he confirmed that the box had several bottles of red liquid. The man who came to claim the shipment was Aaron Stromboli of Damascus, who had told him the substance was an efficacious drug. The quick death of the chief custom house officer is not surprising. Witnesses to the crimes of Israel are subject to a sudden demise. But the reader will perhaps be more interested by the fact that Aaron Stromboli was one of those found guilty in the Damascus murders the very next year. 5. 1840 Isle of Rhodes. This transpired at almost the same time as the better-known Damascus affair. The circumstances are familiar: a small boy, missing, last seen going into a home in the Jewish quarter. A public outrage and demand for action followed, and Ottoman governor Yusuf Pasha ordered an investigation. As in Damascus, this was at the instigation of several European consuls. From here on, the Rhodes case is a mishmash of charges, countercharges, and allegations. The Alliance Israelite Universelle of France and other important Judaic organizations of the day bribed the authorities, paralleling what happened in Damascus. In yet another parallel, Austria withdrew its call for an investigation and supported dismissal of all charges. Sir Moses Montefiore, Adolf Cremius, and the Rothschild barons, financiers of the Austro-Hungarian Empire, were successful. The charges were dropped and the accused freed. The Greek Orthodox clergy and European consuls were left holding the bag, their honor impugned by involvement in a case with no results. And the victim and his killers? The case remained unsolved. No one else was ever accused. 1839 to 1840 were active years for the ritual murder cult. Jonathan Frankel displays a revealing map, showing cases that year not only in Damascus and Rhodes, but at 4 other locations as well, Constantinople and Smyrna in the Near East as well as Schwetz, Prussia, and Jülich, Bavaria 6. He also says, falling into this category, too, were the many criminal investigations and trials in which Jews were accused of ritual murder. Probably the best known of such events in the period under discussion here was the Bilas trial held in Kiev in 1913. Among contemporaries, especially the Jews in the countries involved, though, the cases of Tisza in 1882, in Hungary, of Xanten in 1891, in Prussia, and of Polna in 1899, in Bohemia, engendered hardly less tension. The Damascus affair of 1840, as already noted, caused an extraordinary sensation in its own time. 7. As the reader will soon see, this is an understatement. I don't want to even begin to attempt covering the hundreds of cases of Jewish ritual murder throughout history, or even just the ones pertaining to Purim itself. I think it has been clearly demonstrated here that Jews enjoy a festival of genocide, bloodlust, ritual murder, drunkenness, and gluttony for what they call Purim. Some might have seen the story of the girls who avoided playing during their Purim as just an innocent religious observance, but knowing what Purim really means gives the entire thing a new twist. Again, Jews aren't a religion anyway, they are a twisted race of inbred Neanderthal-like beasts that feast on human flesh and blood. Image link accounts of Jewish ritual murder during Purim are too many to list. The Jews have been draining the blood of their conscious victims, slitting their throats to bleed them out, and making treats with human blood for millennium. Passover is not long away, just about a month from now. Keep a close eye on your children, before they end up crucified, and drained of their blood while still conscious. Anyone defending Jews and their behavior needs to know and understand Jewish ritual murder of non-Jews. This behavior is beyond unacceptable, it's so filthy disgusting, that people should immediately want all of their lands rid of the Jew. Haman tried to facilitate just such a thing, by ridding Persia of Jews in the fable of Esther.